Our next speaker is the master himself, Dr. Deepak Megur. He's got beautiful videos. We all are looking forward to learning how to understand the pathology of unforced surgical errors.
Thank you, Rishi. Just wanted to clarify, because as a slip of tongue from Dr. Nevian, the haptic IOL sticking, it is seen exclusively with the hydrophobic lenses because of the sticky nature and not the hydrophilic lens. That's what he meant, I'm sure. And just wanted to just bring it to the notice of everyone, okay. So, we believe that complications, most complications can be prevented. Believe me, even this could have been prevented. The Argentinian flag sign, even these can be prevented if you're a little bit, plan it well thoroughly, and you can prevent most of it. That should be the mindset of our, as a surgeon, if you can plan well, most of the things can be prevented. And what do you mean by these unforced errors and why do they happen? I would like to classify them as skill-based and non-skill-based. Skill-based also would include a conceptual error, that the surgeon is not having the right concepts. And the more important aspect is the non-skill based, which we have to train the younger surgeon versions. The most people are focusing about the skill ones. The non-skill based also have a role to play. Now, some of the things which I learned over a period of time, this was maybe 14 years back, when this was the way I used to inject OVD. It is purely the wrong way to inject a OVD to fill the chamber with a capsule half open. You're putting it exactly in the bag, and it's going to increase the pressure in already a tense capsule, and it is going to run off. And similarly, it took a couple of years for me to figure this out. So whenever we have opened a capsule and we want to inject OVD, it always has to be in the periphery. It's a very small step, but I still see most beginners do the same mistake. So it's the smart ones are, you have to learn from our mistakes which are already done in the past. You don't have to be learning from your own mistakes. So spend some time in learning from others' complications. So that's one way of learning. Now, this was a case which was posted for a topical phaco routine, and you just take it for granted at every case, and the patient was not suitable. Patient was hard of hearing, deaf, not cooperative, and a simple step of just giving a block would have, this is purely a decision-making effort. Surgeon lacked the awareness of the situation and treated it as routine. So never take anything for granted. Sometimes you create complications and learn some of the concepts. Now, this is something which I learned for posterior polar cataracts, especially in the young and myopes, that just increasing the infusion pressure, trying to maintain the chamber itself, that itself can break the posterior capsule. So we learn more from our complications than our the cases which do well. So the message which I learned from this is never inflate the chamber more. Don't use high infusion pressure in patients with PPC, especially the young ones. And because you're going to induce a spontaneous rupture of the posterior capsule. And this is again a case which I had done maybe about 12 or 14 years, 2011 it was. 25-year-old man, myope, and I have been successful in preventing the rupture of the posterior capsule until this stage. And just before, cortical aspiration, I just filled the chamber so that I don't want to keep it shallow. And then you just see, note the irrigation. Irrigation is around 90 centimeters here. And we don't want it to keep, that was our understanding then. So with a very high bottle height and the chamber already filled with OVD, I just went in with the irrigation on, and we can literally see there are two waves happening. The first wave is of the posterior capsule, and the second wave is of the anterior hyaloid. So in this small clip, you can see that the anterior hyaloid rupture and the posterior capsule are two independent entities. And in these weak eyes, weak in the sense the scleral rigidity is very low. So why does this happen in these people? Patients, when we have high infusion pressure in people who have weak PC, like in PPC, it ruptures. But you need to understand why does it happen. It doesn't happen so often in people who have normal scleral rigidity. But it happens more often in the younger, in the lower eyes with lower, because the sclera is elastic in these eyes. It has a tendency to expand. And what happens is this, the zonules are stretched, making the capsule taut. And that's the reason why, without even touching it, just the high infusion pressure breaks the capsule. So with complications, we all learn most of the things, and it's proven that you don't have to do these complications. You're just a little bit aware of the things. So apart from all these techniques which you have been learning, one additional thing is watch out for your infusion pressure when you're doing posterior polar cataracts. The second thing is always trying to be in the present. So this is a case where it was perfect case. The abrasive nature of my bimanual cannula just ripped open the anterior capsule tear. And at this stage, I'm so livid with myself, I'm shouting at my assistant for not checking and give it to me. And this is a lesson that things can still go wrong. I'm putting the lens, I'm still bothered for my previous case now, what had gone wrong here, rather than trying to be present. You think, no, you just go in and something new complication I've created now. Because my style, I have perforated the posterior capsule here with the tip of the multi-piece lens. It was very unusual to happen. At that time, I didn't realize why it happened, but again, when you analyze it, the tip of the haptic was broken actually, when you go and see. So this was missed because I was not mindful at that particular position. My mind was still worried about the rexis having gone bad. So this is a broken tip. And also I was dealing with a taut posterior capsule. It had become taut because the equatorial extension of the capsule, the OVD would have gone behind and not refilled the chamber. The PC has become taut a little bit. And then you have the posterior capsule, which goes and breaks it. So all these things would have been prevented. This is the downfall can be just like that. So if you're lucky, you always get a second chance. I had a similar case wherein just before injecting, I was mindful, I just go and see. Again, the haptics appears to be shorter than what it has to be compared to the thing. And that is what I could realize here. And then I had a second chance to amend here. So these are the things which we learn from our mistakes. And it's all about being mindful at that situation. So concentration levels do play an important role here. Now quickly, I move into some of the conceptual errors. Now this is a trainee surgeon who has come, who has probably done around 100 or 200 phacos already. But look at the way the sculpting is being done. The nucleus is being literally pushed at or shoved at, okay? So in spite of doing so many things, they have not reviewed their own cases. This is what the mistakes they do. They keep on shoving at the nucleus. So this is not something to do with the lack of the skill or thing, but basically ignorant about the right concept. So it's always better to always be very honest. And this is the way sculpting has to be done. You want the ultrasound energy to cut the nucleus rather than mechanically your tip going and trying to groove the nucleus. So use the right power for the right density of the nucleus. Allow the ultrasound to cut rather than your mechanical showing. And this was a conceptual error. For the shortage of time, I'd just like to go in and conclude so that we can have some time for discussion. So unforced errors can be skill-based or non-skill-based, and I would like to really emphasize that once get your knowledge right, and then focus about developing your non-skill based acts. Decision-making and lack of situational awareness and concentration level drop, these are the most common reasons for the complications happening. The problem really is in the mind, and it's mandatory that we train it. And from our formative years, we have always been hearing that surgeons are born great. You can't make them great. They're already born great. And great surgical hand is a common myth which has already been explored. But I would like to debate on this. Are they really blessed? Of course, some of them could be blessed. Their hands could be much more stable. They could have better eyesight. But I think that is not very key. The key is, how the great surgeon has developed his skill by developing his mind. So what I want to emphasize here is that why he has become a high-performance surgeon is because of his knowledge. He has gathered information from all sources which is available, from his experience, peer experiences, and based on this knowledge, he can anticipate the problems and is well prepared to handle them. And most importantly, he maintains a certain degree of concentration, which is quite high. And it's all about, it's in the mind. So he has fewer complications and also can manage more complex surgery. So basically, the result of having a perfectly trained surgical mind. So to conclude, I would say that for a surgeon, it's extremely important that we remain humble because life has a great teaching lessons. Every time you feel that you have conquered something, you create a new complication which you have not experienced. So staying true to being a student, that's the most important thing which you need to learn from here. I think I'd like to conclude my presentation.
Thank you, Dr. Deepak. Those are some fabulous teaching points and lovely videos. It's amazing how you're able to capture so well.
Just 5 minutes we have for discussion. I'd like to ask Samresh. You showed the last clip of the DMD happening while doing your side port hydration. What tip would you want to give to the delegates here to minimize that step. It's a very common mistake which most of us do. It's on, I think.
All right, so the one thing is I've stopped doing overzealous hydration. Especially with the fellows, it's I think better to close the eye soft for them than to try to push, because that happened because not only did the fellow did not recognize, but he kept on pushing to make the globe tight. And that is what caused the descendants to find a cleavage point and come. In fact, I've had patients who've had almost PL negative CRAOs because of tight incisions and situations. So please keep in mind, and don't hydrate at the edge of the incision. So you have a full wall of the incision on both sides. Go in the center of the wall and hydrate there to see the bubble, that Mickey Mouse appearance coming up, rather than going to the edge, because edge is where the decimals is cut and it can...
And I think I'd just like to add on to it, direction of your cannula. It shouldn't be directed up like this. It should be directed towards up. Don't direct it down when you're trying to do hydration. By doing down, you're going more likely enter into the plane between the descemetes and the stroma. If you direct the cannula up towards the anterior stroma, you're unlikely to hit that. Second thing, Dr. Rishi, how could I have prevented the entering into the interface of the graft? If you had a second chance, how would you have prevented that?
So I think the key is to make sure that your entry is well away from the edge of your graft.
Okay.
Okay, so in my case, the entry was very close to the edge of the graft, and that is why I kind of didn't realize what I was doing. And second thing is, when you're going in, you have to make sure that you don't get resistance. If you're getting resistance, and your direction of the entry again has to be more vertical. So
yeah.
These
So
two points.
my understanding was I would have made the eyeball a little bit harder by putting viscoelastic, and maybe incision should be a little bit shorter, not a longer one, and direct your probe towards the vitreous rather than ending like this.
More
so these are situations probably, because the same principle will apply when you're trying to enter in an eye where you're expecting an eye with descemet detachment. Very old patient, thick carcass, compromised endothelium. So what would be our recommendation is, never go in with an irrigation open there. Always fill it with viscoelastic so that IB is very taut, and then you enter. Make a shorter wound so that you don't graze the descemetes of it. That would be the thing. Any other questions from the audience?
Yes, Dr. Meena.
Madam showed how to, I want to learn from her, how do you do pars plana vitrectomy for an anterior segment surgeons? Any tips?
Basically, I should admit I have been a trained VR surgeon, so it's easy for me. The tips for an anterior segment surgeon is to have a simulation training first, okay? The simulation training will help you guide what is a pars plana entry and what are the steps you need to undertake. Always hypotony would be the first issue which you need to deal with when you're doing a pars plana entry, when the nucleus has been already removed from the eye. When the nucleus has been taken away, the hypotony would be an issue. So some surgeons prefer to use an AC maintainer, that is also an alternative, or use viscoelastic to maintain the right pressure in the anterior chamber. Make a pars plana entry around 3.5 millimeters from the limbus with the MBR blade, and always try to visualize the cutter which you are having. You can also use your irrigation cannula to maintain the anterior chamber. The cutter can have a pars plana entry at around 3.5 millimeters from the limbus with the cutting port facing towards you. Okay, initially, but later you can also turn the cutting port towards the vitreous and compartmentalize and try to separate the vitreous away from your anterior chamber. Whatever the vitreous is trying to come is coming from the posterior segment to the anterior chamber. By cutting edge facing downwards, you are going to compartmentalize and separate the vitreous into two fragments. Then you can either suture the wound of entry, and sometimes, you know, with 23G trocar cannula entry, it is self-sealing. So these are the options you have.
Do you always use Kinocort or dilute triamcinolone for these cases?
Yeah, that is the reason, because we don't visualize vitreous so easily. Vitreous is invisible, and certain times we tend to mistake the viscoelastic as vitreous. Many a times it has happened with me itself. So to identify the vitreous stains well with the triamcinolone particles. 1:4 dilution we use, but certain centers they use 1:8, and 1:10 is recommended by American Academy.
Thank you.
Yeah.
Sir, as you have told that we have very often find hydrophobic lens, leading haptic is just pointing towards the right instead of pointing towards the left. What should be the preventive steps so that the rotating haptic tip do not puncture the PC?
So that usually happens when there's something gone wrong with the loading and it's coming out. So it's already halfway through. It's preloaded. Preloaded. Yeah. So what I basically do is I have the second instrument. No, I just bend that haptic. So my first prevention is making sure that doesn't go pointed and hit the iris or the bag. So I just bend that haptic and slowly inject. And sometimes I just withdraw the cartridge also because you don't want to push the lens too much in the lower half of the eyeball. So I just retract my cartridge and keep pushing. And once it is inside, then only it gives me time to know how it's twisted and come out. And then you can maneuver it however you want. So the initial thing would always be with my second instrument, I just try to bend that thing which is pointing so that the smoother surface is there and slowly inject the remaining of the lens. Anything else?
If I can just add, when you see something unusual happening, when you're halfway through, just stop there, refill the chamber and the bag with OVD, okay? So if you're sensing something is wrong, the haptic is not opening all right or something is there. So even maybe if you're using hydro implantation also, then maybe there's a time to replace with an OVD, deepen the black, because even if it goes or jumps out or something, you don't want it to go and perforate your PC or the entry cap.